Onc Live Insights is a video editorial program produced by Onc Live.
It's important to realize that not all EGFR mutation tests are identical. We generally use a PCR-based approach. EGFR positivity by immunohistochemical analysis is actually quite common, about 60 to 80% that does not correlate with mutation status. Amplification can be seen anywhere from 40 to even 60% of individuals. Again, no direct correlation with mutation status. So with regard to first-line treatment with the TKI, it is imperative that mutation status be established. And neither IHC nor FISH nor any other approach are substitutes for mutation testing. There are 8 separate, standalone, prospective, randomized clinical trials that have all shown the same outcome. And those whose tumors harbor an EGFR mutation, a first-line TKI, whether it is gefitinib or erlotinib or afatinib, is superior to chemotherapy with respect to response rate, disease control rate, progression-free survival, symptom control, and quality of life.
Currently in the U.S., there are 2 FDA-approved EGFR inhibitors for first-line treatment. And one of the main themes is that we have learned that first-line treatment with a targeted agent is a good thing, especially if you can get the information in time. Sometimes patients can't wait for that testing to come back. They may be ill and symptomatic from their cancer, and you have to go ahead with chemotherapy, in which case targeted therapy can still work in the maintenance setting or in the second-line setting. But ideally, you will find out about this EGFR mutation at the time of diagnosis, and you can make a first-line therapy decision based on that. So how do we choose in the clinic between the 2 FDA-approved drugs, erlotinib and afatinib? They're both very good drugs, and I think the bottom line is that they're actually very similar. When you look across trials, an important point is they haven't been compared head-to-head yet. And so I think when those studies do get completed and we have actual head-to-head comparisons, we'll have a lot more data to stand on to say this has better efficacy, this has better toxicity, this is good for this population of patients. Right now, what we do is look at the different studies that have been done with each drug and try and compare across studies, but that's never as valid or robust as a head-to-head comparison. So using that type of data, comparing across studies, I think what we see is that afatinib may be a little bit more efficacious than erlotinib and may have a little bit higher toxicities. So it's a balance. And I think the one subgroup of patients that it's most clear that afatinib has a little bit higher efficacy is in the EGFR mutation patients that have the exon 19 deletion mutation.